speakers rather than we want to hear our speakers rather than me. And we have two speakers today. The first is Dorothy Loam, who I have had the pleasure of actually meeting in person, who's from Lusaka in Zambia, and she's a clinical oncologist, and she's going to talk about earlier diagnosis through screening. And then we're going to go straight on to hear Dr. Deo Ruhangaza, who is a pathologist from Rwanda, and he'll add to that through diagnosis through pathology. So we'll start with Dorothy. Go ahead, please.
Vanessa, am I able? Great, thank you. Let me just share my screen and start the slideshow. So good evening, everyone, and it's such a pleasure to be part of this group. Thank you very much for the invitation to engage on a topic that I truly find interesting, and it practically is has a big impact on how we practice oncology in Sub-Saharan Africa. So basically, I'm going to go through the low-cost screening methods and essential imaging, and then Dio will take us through the pathology aspects. So starting from the basics, effective screening tests really should find a cancer early. They should reduce the chance that that person who has cancer will die, who would possibly have cancer will die from that cancer. And it should have more potential benefits than harms. And some of these harms that can be seen in screening tests, particularly those that are invasive, could be bleeding, physical damage. You've also got the psychological discomforts like inaccurate test results that could cause anxiety and overdiagnosis as well for cancers that actually would not have caused problems for a particular individual and would probably not have needed treatment in them in their lifetime. So it's really important to understand that screening is not, it's not the panacea of the cancer problem in Sub-Saharan Africa. And what we really do have a problem with, particularly with maybe people who survive cancer or people who have an experience with cancer, and in health systems that are not organized and have an opportunity for people to kind of come up with something. Screening is really a hot topic that you need to control. And the first thing people want to do is say, let's just screen without thinking about the downstream effect of finding cancers that you have no infrastructure to actually support. So again, there's a lot of literature out there, and I thought I could just remind everybody a little bit about the statistics. There's a really good paper by Waghardt et al. This information is also found in cancer.gov that talks about, really understanding what does screening mean. First of all, when you find more people with a particular early cancer, it doesn't mean there are fewer deaths. And the actual definitions of lead time and length time bias confuse the interpretation of survival. So when you look at this top diagram I've got here for lead time bias, you've got this person without the screening who would have had the cancer diagnosed at the age of 67, and they would have died at the age of 70, meaning they've got 3 years with the cancer. And when you look at their 5-year survival, it's equal to 0. However, when a paper reports that with screening, this person's disease was discovered at 60, their 5-year survival will be 100%, and they'll be dead at 70. So it doesn't necessarily change the fact that they will die at 70. But when you read those papers and you're not truly understanding the statistics behind it, you'll think that, oh yes, screening actually improves the 5-year survival. The same thing could be said about the length time bias, which is also overdiagnosis. So without screening, and this is just about the addition of the group of people, like without screening, you've got 1,000 people who have progressive cancer, right? And 5 years later, you've got, if you have 400 who are discovered over 1,000, and that's 40%, you have 400 alive and 600 dead. Now, if you have 2,000 people with a non-progressive cancer, and this is usually applied with the slow-growing type of tumors, this is actually seen in slow-growing type of tumors, and you have 1,000 people with progressive cancer, you've got that 80% 5-year survival. But really, it's the fact that it's slow-growing anyway, and it hasn't really made a difference, but you just have these shifts because of the intervention of screening. So when you actually look into the numbers and see the impact, the cost of a screening system on a health system, particularly in low-resource countries, the absolute improvements for mortality are actually quite small. But the unique thing that I find in my practice, particularly, is the fact that our populations tend to be also quite young. The life expectancy of patients are not those that actually get cancers. And the bottom line of what I have found when we're talking about cancer screening is actually to think about cancers that can be prevented rather than found early. If you can truly prevent the disease process from actually becoming an invasive cancer, then that becomes very useful. And of course, later on in the presentation, we'll talk about the perfect child, which is the cervical cancer program, where you're able to prevent a cancer happening, and then you have a really effective intervention in a population when it comes to cancer control. So when we talk about cancers that have proven evidence, and again, there's a lot of material out there. The thing about screening is that you can't really extrapolate it. You can't really you can get guidance from other countries, particularly where the studies are done, but you can't extrapolate it as easily into your own population. But of course, cervical cancer, we've seen the wonders of what screening does there. And this is a secondary prevention method, primary being HPV vaccination. And the different methods that are there are VIA, HPV, and Pap smear. And each one of them have got their own evils that you need to really understand. For example, VIA alone will allow you to see what we call precancerous lesions. However, you could over-treat patients because you don't really have evidence whether those changes are really precancerous or they could just be something abnormal. HPV testing is fantastic because it allows you to know that the precursor that could have been there. But in the younger women, they get HPV all the time and it clears off. Also, it was considered a very expensive test in the past, but I think that has changed over a long period of time because better, more cost-effective HPV testing platforms have actually been expanded. And for example, in Zambia, where we have a high prevalence of TB, we find that sharing the HPV platform with the TB program actually helps us to save costs, and that's what we've been leveraging on. Pap smear, of course, is not feasible in countries where you don't have technologists. It's very labor intensive and resource intensive. So Pap smear is generally applied in more developed countries. Then you've got colon cancer, and the modalities that are used are stool tests, which are pretty simple to do as an initial step. And then you've got now the more technical intensive modalities like colonoscopy and sigmoidoscopy, which of course, again, require quite a bit of infrastructure and human resource. So mammography is also very misunderstood. I've been in fora where African women are being told that no, we shouldn't actually be introducing mammography, and they're up in arms and they're like, why are you telling us not to do self-breast examinations? Why are you telling us not to have mammography? You don't want to discover our breast cancers early. And you have to explain to them what it means to have an effective cancer tool, because there's no, if we discover the cancers early, do we have the infrastructure to actually deal with that disease, with the early disease? Do we have all the, the resources that we need? Then, of course, we've got low dose helical CT for lung cancer, and this is only indicated in heavy smokers, people with an over 20-pack year of smoking. So other screening tests that have no proven benefit in terms of mortality are breast, ovarian, prostate, colon cancer, liver cancer, skin cancer, and those are the other modalities that are used. So I thought it would be nice to say, look, of cancer in Sub-Saharan so that we can reduce the cancer mortality, or at least make a difference in the morbidity and mortality. So this map is from GlobalCan, and it shows that breast and cervix are head-on. Those are the most common cancers, and those are probably the early diagnosis or prevention programs that you actually want to run. So going now into the meat of what we're talking about. So the issue there is to actually, cervical cancer being a case study of what it would mean to scale up research for screening is, the rationale is to actually have precancerous lesions to detect them and then to treat them. And they're numerous. Again, it's easier said than done, because you've got to come up with a system where the patient doesn't have resources and the system doesn't have resources. So if you want to catch it, this is not an organized system where someone will get on the bus and then come back and it's so easy for them. No. When you have, you've got to apply the fact that when you have your patient in front of you, that of course, there are different tiers depending on the transformation zones and everything like that, where it's unavoidable for the patient to move to the next step. And this is where research comes in, understanding the barriers of how a woman can finish her journey from the time she enters the system, offering herself for screening, to making sure that you've put systems in place. And it's not just about something falling and happening automatically. For her to move, for example, from a VIA clinic, going on to a LEAP clinic, and if the LEAP clinic finds that she's got invasive cancer, moving on to the radiotherapy center or the surgical oncology center for further treatment. So that's very, very important. And there has been some good work that has been done. I mean, the sensitivity of VIA and VILI have been, we've got a lot of papers from Sub-Saharan Africa where people have proven that it's cost effective. But even more exciting in the recent years has been the combination of the two, to reduce the overtreatment of women with precancerous lesions, to understand that these are the ones who are HPV positive, and then they follow a certain pathway. And of course, because we are able to now implement HPV testing into our cervical cancer screening programs, we're only going to know how we're going to be dealing with those mathematical issues where a woman is HPV positive but VIA negative, or HPV negative and VIA positive, and all those nuances that you're supposed to answer those questions as they come up in the clinics. So this is quite an old paper that was published in the New England Journal of Medicine, and it looked at the cost effectiveness of cancer screening in 5 developing countries, India, Thailand, Kenya, Peru, and South Africa. And you'll see very clearly that, of course, when you look at the cost, which is here on the left-hand side, and you'll see very well that VIA wins through and through. Pap screening, not so expensive. And I must say that I think this HPV testing was a time, I remember the first time we talked about HPV testing, you had to run it through 100 assays and so on and so forth, and we just didn't want to even implement it. But thank God for an evolving system that we're having HPV testing that is much better, and also HPV testing presenting an opportunity for women to self-collect a sample is actually something very good, because that stigma that came along with the speculum examination, or in modern societies where women don't want to address in front of the doctor and all those things, it's much, much easier when they're able to self-collect and then you process and follow up. But at least when I speak from the background of my practice in Zambia, it's really going to take a lot of work for us to really figure it out and not go back to the time that we used to lose women. Like, we would see a sneak peek of them, they come for the screening, we see them, but then we lose them again because you just don't have a system for letting them move through the whole health system. So very quickly, I'll move on to also share this paper that was done by Mwanahamuntu et al. And they were describing the cervical cancer prevention initiatives in Zambia as an example of a resource-constrained environment. It's a very good paper to read because it talks about the processes and the outcomes, the sort of things that you need to put in place. And the cervical cancer program in Zambia is a good example of something that started off as a research project and then expanded, handed over to then become a national program. I think they started with something like 5 clinics in the capital city, and now practically every district, of which I think there are like 150 plus districts in Zambia, has coverage of at least one VIA screening over a period of 10 years, which is not an easy thing to sustain, because that's usually the issue. A project comes into a country, the project finishes and people move on. But it's been great that consistently from the beginning, using this framework, they were able to actually develop this screening program to reach the levels that it has today. I hope I'm doing okay on time. So some of those secrets that they've shared in their paper is that the first thing is shared leadership with the country. When you are actually researching something that is supposed to benefit the country, it shouldn't be them and us. The project must actually integrate into the workflow of the actual health system. There should be foresight, and if possible, to have shared leadership between the country and the actual research efforts that are happening, which can be quite hard, but you have to overcome all those things. Then the other thing is a quality assurance and improvement issue, which is really an issue in resource-constrained environments. Implementing a project is one thing, but ensuring that the quality is kept up to scratch is another, particularly in places where clinical trials and all those things are not something that are well set up. Then the other thing is the connection between the nursing level and the physician level. Having that delineation between the two levels with the patient at the center of the effort that you are actually managing, and also the data management system, of course. So the second part, which I have really summarized into one slide, when you think about the issue of screening and making screening count for something in a low resource setting, is essential imaging. For cancer care, the principles I felt could be summed up into this. First of all, it has to be cheap, but not cheap in the true sense. Like cheap, it has to be cheap enough for it to work both ways. The patient must be able to afford it. You shouldn't send the patient away for screening for a diagnostic scan that will take 6 months. Then you defeat the purpose of actually treating and staging the cancer, and that happens a lot. So basically the domains here that are on the right, because you've got all these different levels in cancer control, from the screening, diagnosis, staging, therapeutic, and monitoring. Whenever you apply these principles of cheap, it should have a low human resource burden, low maintenance cost, and it should be versatile. And we all know that our current practice in cancer control does not allow that. Usually, like cervical cancer actually is a good example of how ironic it is that MRI can be a gold standard to look at the tumor, when MRI is not accessible, even in developed countries. It's not every center that will have an MRI easily accessible for the radiotherapy treatment process, for example. And it's about time that we researched more on the ultrasound aspect of applying that, having a cost-effective modality at each and every point of saying, this is where the cancer burden lies. These are the realistic imaging modalities at each point in the domain. So you could have a mix. CT scan has become more commonplace now. Previously it was a little bit inaccessible, but I want to believe that most places have access to CT scan, and MRI is the one that continues to be a burden with all those issues of radiologists, helium, and all those other things. PET CT quite unattainable as well, and bone scan, SPECT, all those things. But ultrasound and CT scan should be able to get us through most cancer control issues. Again, with imaging, something that when you keep reading about cost-effective imaging in cancer control, it's very, very difficult to transfer the experience, even between Canada and America. whether you like it or not. So what more between developed countries where most of the research is happening and developing countries? So it is something that we must make sure at least the systems level analysis of your experience, and to have a constant feedback mechanism to say, is this working, rather than the copy and paste that can quite go on for a while. Yeah, so basically, I think that was the meat of what I had to share for my segment. So I'm going to stop sharing now and allow Dio to take on the pathology aspect.
Thanks, Dorothy. That was great. So, Dio, it's over to you.
Thank you. Let me share my screen. Can you see my slides?
Yes, we can.
All right, thank you very much, and it's a great pleasure for me to be able to be involved in this course, and I'm going to talk about the how we can stimulate earlier diagnosis through research focusing on pathology and the importance of pathology in early diagnosis. So this is beautiful images from my hospital institutions. This is the Butaro Cancer Center, as you can see, in the middle of a typical rural Sub-Saharan African environment. And on the other side of the hill, you have the University of Global Health Equity, and both institutions are affiliate with partners in health, non-profit organization. But the hospital is a public institution. So I'm going to focus on the role of pathology in cancer-related research and how we can bring some ideas on research on our setting, focusing on challenges that we are facing in our everyday life in cancer control. So I will finish this talk with discussing some ideas on biomarkers in cancer diagnosis with an example of breast cancer biomarkers. So pathology is critical for screening and early detection and diagnosis, even in monitoring the response to treatment, and it's provide important prognostic information, and it also plays a key role in cancer research. So whenever we try to collaborate with clinicians and pathologists, we may end up really bringing out robust research activities that can even bring local solutions for cancer control. So when we think about early detection, we would focus mainly on raising the awareness in accessing to care and improving the way we clinically diagnose cancers, and the pathology, strengthening our pathology services and improving our referral systems, because we are not yet at the level of being able to treat cancer in all our public institutions, for example. And at each step, there are areas where interventions can be done, and these are also areas where ideas of conducting research may arise from. This is an example of this study that was conducted in Rwanda, where the authors were the delays in breast cancer presentation and diagnosis at the rural cancer referral centers in Rwanda. And you can see how even when we talk about the delay, we sometimes forget that we even have a system delay where our health system would contribute in delaying the cancer diagnosis. And as you can see for this breast cancer research, 52% of patients were at stage 3, while 24% were at stage 4 disease. If you combine these, you are at more than 70% of advanced disease, and the intervention would really focus on improving what these research findings are showing us. This is an example of these research activities that will bring solutions to our local problems. The possible sources for delay in cancer care are many, from financial issues from the patients themselves and our traditional belief and seeking for traditional medicine first before consulting the hospitals, and the fact that early clinical signs of cancer are not easily recognized at the primary level also. And we also on that add system delays that are related to the tissue diagnosis, the staging with imaging, and even the long delays with surgery appointments. So this is another example of a simple project that would try to improve the really problem that you are seeing in the delay in the diagnosis. So this research was focusing on improving the turnaround time in the pathology diagnostic, and from the fact that the lab did not have a pathologist on site, they would prepare slides and tissue blocks and send them elsewhere. And they ended up having an idea of using the static images and sharing the images with pathologists at distance until they ended up having a visiting pathologist that would come in the lab and sign out cases. And they were able to move from 30 days up to 5 working days. So the challenge that you are facing in access to pathology services in Sub-Saharan Africa are, I think, are relatively similar with different institutions. So it's the shortage of staff and a lack of retention policy and inadequate infrastructure, and the problem related to lack of local suppliers with contribute to frequent stock outs, and the lack of competent hospital engineers for maintenance of pathology equipment. And we are also, many of our labs are still at the level of doing the routine H&E and probably some IHC stains, and we still lack access to new molecular diagnostic technologies that can guide target therapies, for example. So there are different solutions, like working with partners, with industries in using the telepathology. And we also need to use new diagnostic technologies that can facilitate the pathology practice in a resource-limited setting. So we don't have pathology labs in all our public institutions. We need to improve sample transportation systems. So from the remote areas to centralized pathology laboratories. So this is an example of a digital pathology technology that we used in 2017 when we're trying to diagnose hematological malignancies, as general pathologists would request most of the time experienced pathologists in different fields, and we were able to collaborate with volunteering hematopathologists, sharing the digital pathology images, and real-time consultation. So we ended up developing this research project, which ended up giving us the capacity also of having the telepathology equipment in our lab up to now. So my last talk is going to involve the breast biomarkers as example of what we can do to improve the cancer diagnosis. And we all know the role of these biomarkers as important prognostic information and how they can guide the treatment. And the molecular subtypes are coming from the data from the DNA and mRNA protein expression that shows that we basically have two groups, the estrogen negative and estrogen receptor positive, and in each group we have a subset of HER2 positive subgroups. So these intrinsic subtypes of breast cancers ended up showing that breast cancer is not really a single entity. And if you consider the ER positive breast cancers, the low end of spectrum or Lumina A, and the high end of spectrum or Lumina B. So the pathologic features are different as well as the prognosis, and the Lumina A have a high expression of ER and PR receptors, and they are HER2 negative with a low Ki67 proliferation rate. They are often low-grade tumors and with some particular histology types like tubular and mucinous and the moderately differentiated lobular types. So they have particular genetic abnormalities with few genetic changes in copy numbers involving chromosomes and chromosome arms, and the PI3 kinase pathway is the one mutated in most of these type. For the high end of spectrum or Lumina B, their level of expression is low, and sometimes their PR is typically negative, and they can be HER2 positive or negative, and they have a high proliferative rate on Ki67. So they're often grade 2 or 3, and is the most common type of cancer in individuals with BRCA2 germline mutation in case they are HER2 negative. The metastatic pattern is also different because the ER positive cancer most metastases into bone, and the visceral involvement is a little bit lower compared to the ER negative tumors. So patient with ER positive cancer metastasis can survive with their metastatic disease for many years. You probably have patients in this situation in your patients that you treat. The HER2 positive carcinomas have in this group, like half of them are ER positive and the other half is ER negative. They are usually uniformly high in ER negative. The positivity, the membranous positivity is high, and it's tend to be borderline in ER positive tumors. So they are often a high-grade tumors with extensive ductal carcinoma in situ lesions. The last category is these triple negative tumors, and they also have a high proliferative rate, usually high grade 3, and extensive DCIS lesions that will be absent or even scanty in some of the tumors. And we have special types like the metaplastic, the medullary, and that are known to be really triple negative. We also have some triple negative tumors, but that do not really have a relative, that do not really have a poor prognosis, and these are adenoid cystic carcinomas and secretory carcinomas or adenosquamous types. Their metastatic pattern is more going to involve the viscera and the brain, and the patients will die because of these metastases. So the long survival with the metastatic pattern in this group is really unlikely. So when we think about these breast markers, there was an idea that African patients have are really receptor poor, but many studies that were conducted ended up finding that the negativity was probably related to how the sample is handled, especially in the fixation process. When people were able to control this, they ended up finding relatively similar percentages with Western countries. So the issue now with testing for these biomarkers is that we are most of time doing it manually, and you need experienced technicians and pathologists for interpretation, and it's not routinely performed in many labs, so you need to send a tissue block elsewhere for testing. And so there are also new technologies that can simplify this, and I can just talk about these expert breast cancer Strat4 cartridges from the CFID company that are allowing you to test for all the three biomarkers at the same time, even including the Ki67 in an automated way, using a cartridge that resembles that cartridge that used for tuberculosis diagnosis. And these are the kind of technologies that we really need in our limited resource settings, because it can improve a lot in diagnostic testing, especially when we are dealing with a limited number of staff and experienced technicians. I think I'm going to stop here, and I'm just going to conclude that we really have research projects that are aimed at improving cancer care in our environment, and we need to focus on ideas that are coming from the challenges that we are facing in our everyday life. So we don't necessarily need strong robust molecular research projects to improve the cancer care in our limited resource setting. So those research projects that are aiming at, for example, describing and improving the cancer awareness at the level of the community, improving the early detection, and improving access to pathology services would really have a strong impact. And we need also to encourage our institution to fund those research projects. All right, I think this was my last slide, and thank you very much for your attention.
Thank you, Deo. So we'll just let people, please turn on your videos if you have the bandwidth to support them. And
okay. Okay, so I want to present the research we did sometime between 2014 and 2016. And the title of the research was Impact of Community Health Educators on the Uptake of Cervical and Breast Cancer Screening and HPV Vaccination in Rural Southeast Nigeria. So I work at the University of Nigeria, Nsukka, and also an honorary consultant gynecologist at the University of Nigeria Teaching Hospital in Enugu, Nigeria. So this study was actually funded from the Conquer Cancer Foundation International Innovation Grant This was actually the very first edition of that grant. We were lucky to have been selected. And so we did it with the funding that came from that grant.
I don't think you were lucky. I think you deserved it.
Oh, thank you so much. All right. So this is a map of Nigeria inside Africa for those that might be wondering where Nigeria is located. So we look at the size of the problem before then. And we have in Nigeria more than 200 million population, total population. Unfortunately, we cannot say we have a very accurate population figure, but these are estimations from the based on 3% annual growth annual population growth rate from the last census. So that's our estimate, and we thought that females account for more than 100 million of these 200 million people. But then looking at females aged 20 to 69, there are about 50 million of them. And we have awareness of cervical cancer less than 30% in the entire nation. And among these 15 million women, we have less than 10% of them have done one previous cervical cancer screening. So there's a huge burden here, huge burden of low awareness and also huge burden of a low uptake. The same goes with the breast cancer also, and then the HPV vaccination. So our objective was to evaluate the impact of community health educators on uptake of cervical and breast cancer screening and HPV vaccination. What we thought we needed to do here was to educate a group of people so that they could develop, so they could step down the education home to home on the population and then see what the impact would be like. So our approach was more like a pragmatic population intervention study. We took the before and after design. It wasn't controlled. So each participant served as a control. So we selected 4 communities via a multi-stage random process. So in Nigeria, we have, Nigeria is divided into states for administrative purposes. We have about 36 states. And in the southeast area where I come from, or where the study was done, there are about 5 states. So through a random process, we selected 2 states from these 5 states. And then in each state, we went to the next stage again by selecting local government administrative areas. Now there are about 44 local government administrative areas in these 2 states. And therefore we wanted to choose 4 of those local government areas. So we chose 4. Then we went again to the last stage where from each of the selected 4, we chose 1 community from the local government administration areas. And we are more interested in women that were more than 30 years old. So pre-intervention, we took baseline data on cervical and breast cancer prevention utilization. So we tried to find out how many of them knew about breast cancer, how many of them have done a pap smear before, how many of them have done a VIA before or a VLA before, and then how many of them have done a clinical breast examination in any of the clinics before, and of course awareness of that too. So we took that data, and also during that period of pre-intervention, we did training of the primary healthcare nurses. So in Nigeria, you have this arrangement where every community has a primary healthcare center. It's a small health outfit that is funded by the government. The nurses were employed by the government, but they are there to render primary health services to each community. So that's already existing. So what we did was to pick nurses from these centers, from those areas we have actually chosen from the random process. Sorry, from the multi-stage random process. So we chose the nurses to train them, and we did a 7-day intensive work type training. We got a lot faculties from people who have been working in these areas, breast cancer prevention and cervical cancer prevention, mainly gynecologists and breast surgeons. So they did the training. After that, we still went ahead to do a 21-day hands-on field training. So here, prior to this time, we had these community outreaches we've been doing from time to time. We go from one community to the other and then do free cervical and breast cancer screening. So during those screening, we also do a see and treat method where those who we think have cervical precancers based on our VIA and VILI results, we usually treat on site with cryotherapy and sometimes with thermocoagulation. So that's where we did this 21-day training for these people. So they really participated to know, to kind of translate what they learned on the workshop to practical things in the field. So we taught them cancer prevention communication skills. We got people who are experts in communication skills, and they taught them how to on cancer prevention, cervical and breast cancer prevention. So we also taught them how to do visual inspection with acetic acid, as
We are losing your voice, Chibuke.
I think he's freezing.
and brought the severus. Hello, can you hear me?
We can now.
Yes.
You were freezing before.
Okay, you can now. Okay, sorry.
Yeah, it seems okay now.
Okay, so we were able to get HPV vaccines in these places, but it's not for free, unfortunately, but we got them at company prices to make them readily available at these primary health centers. So that's what we did during the pre-intervention. So during intervention, what we did was door-to-door home-delivered education on cervical and breast cancer prevention. So those women, those nurses, we trained both in the classroom, in a workshop style method, and in the field, now move from house to house within their catchment location, and delivering this education on those women one-on-one on cervical and breast cancer prevention. So they did this, and for each person that got the education, the post-intervention starts the next day. And so post-intervention was 6 months. We evaluated after 6 months from the time they received the training or the education at home. So we try to see what they have done with the education, and we try to see if they've been able to go to the primary health centers for voluntary cervical cancer screening, if they went there also for clinical breast examination, and if they were able to take their children 9 to 13 years of age for HPV vaccination at this center. So these were the primary things we checked or we evaluated to see if the education intervention we did actually worked. And this is what we got. Pre-intervention for cervical cancer screening, about 1,327 women. Am I still being heard? Sorry.
Yes, you're okay.
Okay, perfect. So we found out that pre-intervention, only 42 women, which represented about 3.2%, had had a cervical cancer screening, a previous one before that time. But 6 months post-intervention, we had had a
You're frozen again. Chibuke, I suggest you turn off your own video and you may get better sound. Can you hear me, Chibuke?
67.
Yeah, we're losing you. I suggest you turn off your video. We don't need to see your face, and hopefully we may get better sound. We're still seeing your video, but I would turn off your video and just speak to the slides, and because your voice was freezing. Let's try that.
Okay, so I've turned off your video, Dr. Chigbu, but you are muted, so.
Can you hear me?
Yes, now we can hear you.
Okay. Wait, can you see the screen?
We can't see your slides at the moment. Now, here we go. Yes, now we can.
Oh, perfect. Sorry about that.
That's okay.
Okay. So I was talking about the HPV vaccination. Only 2 children had a HPV vaccination by the time before the intervention. But after the intervention, we had about a jump from 0.9% of the children to 33.2%. And that represents about 34-fold increase in HPV vaccination uptake. So clearly our intervention worked in all 3 areas we tried to assess. In the area of cervical cancer screening, there was 21-fold increase. In the area of clinical breast examination, there was 14-fold increase. And then in the area of HPV vaccination, 34-fold increase. So prior to this time, we know that the uptake of voluntary uptake of cervical cancer in Nigeria is somewhere below 0 to 18%, depending on the population that was studied. But our studies showed that we could actually up this to 21-fold increase. So we thought that what brought about this could have been the people we used to deliver this education to them. Remember, I said earlier that we use women who were working, nurses who were already working in the community health center. So these people already have trust, within the locals. And so when they go to those houses to talk, they were listened to and they were able to make good use of what they were taught. And like I said, the vaccine was not frequent. And if at that time we did the study, a complete dose of the vaccine was about $12 at that point in time. Sorry, 1 dose was $12, and they were able to do that. And if I should bring it down to the Nigerian level at that time, a complete dose of the vaccine would cost about half of the national minimum wage. So that could give us a sense of the cost of this vaccine, and yet this vaccine was taken up by quite a significant number just because they were told about it one-on-one by nurses that they trust who came to their homes to discuss with them. So I would like to conclude that our study showed huge increases in voluntary uptake of cervical and breast cancer services, as well as HPV vaccination. And we also showed that this could be an effective, low-cost, and easily sustainable model for low-income countries. Why easily sustainable? Because you are not going to employ any new persons to do this, just to train the nurses that are already existing in the health centers. Just give them training and then they deliver. So there's not much money will be spent hiring new persons or doing any new things. And I think that this is very something that should be looked into by many, from low-income countries. Then there's this possibility of effective integration of cervical and breast cancer prevention services into existing primary healthcare system, which is important. In Nigeria, we had this routine immunization, which was done, for the 6 childhood killer diseases, which has become some kind of a routine because it was integrated into the primary healthcare system. If we can integrate this breast cancer screening, as well as the cervical cancer screening into that primary healthcare system, it should be able to be effective going by what we found out from this study. I think this should be my last slide. Okay, I'm trying, this is what a picture of the training section we had with those nurses. Quite some of them taking notes during the training. And that's me there having a picture with them, a group photograph with them during the intervention training. I think that's all I have for now. Thank you for listening.
Thank you.